you'll see a lot of literature and a lot of folks trying to figure out how to get rid of opioids. Fine. You have your different pain management strategies. But our reduction in opioids was a consequence of a holistic approach to managing the patient perioperatively that restored them to full mobility quicker and put them back in their lives with their families quicker.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. I have a special guest with me today. He's one of my colleagues. We work together in our health system. Dr. Marc Gerdisch is Chief of Cardiothoracic Surgery at Franciscan Health. He is Associate Professor of Surgery at Loyola University School of Medicine. And he's a partner at Cardiac Surgery Associates. And I wanted to invite him to Parallax to discuss a neat paper that he's published as first author. So congratulations, Dr. Gerdisch, on your publication in Annals of Thoracic Surgery. And he discusses a method in cardiac surgery, and he's going to talk more about it, but it's a rigid fixation followed by enhanced recovery. It's part of it's a protocol, comparing it with the traditional wire cerclage following bypass grafting in patients who have coronary disease. And I think the findings are startling and very, very interesting in that he's reported opioid use and its decrement following, perfection of these two procedures or processes or techniques. So with that introduction, Dr. Gerdisch, thank you so much for doing this for us, and welcome to Parallax.
Oh, thank you so much for the invitation, Ankur. Glad to be here.
I'm going to start by asking you as to what the motivation was for you to conduct the study at the first place.
Yeah, so this has been a several-year journey for us. I think kind of starting at the end in a sense, I think it's important to recognize that the study is an all-comers study for sternotomy. So there are coronary bypass patients, but there's also everything else. So if somebody had a triple valve redo with a maze and bypasses or whatever operation they had, this was an all-comers look at our practice over several years. There are not many single valve operations because those essentially all are done minimally invasively, not with sternotomy. But pretty much everybody else, folks who have coronary bypass surgery or bypass combined with other things, multi-valve, et cetera, they have sternotomies. And that still is the dominant method that people are approached for in heart surgery nationally. So our goal here was to address what we kind of saw as the difference between what the experience was for a minimally invasive patient, where we had really kind of mastered certain techniques for diminishing trauma, managing discomfort, achieving early discharge, avoiding challenges to recovery, including going back to full activity. And we wanted to make it equal. We wanted to achieve over time that every patient having heart surgery with us would have the exact same order set, would have the exact same expedited recovery. And we had the good fortune of participating in a randomized controlled trial about 9 years ago that looked at rigid plate fixation, which is a method for not only approximating the bone, which is achieved with wires, but stabilizing, creating a rigid sternal fixation, a rigid orthopedic repair of the bone. And we participated in that study, and it became obvious to me that this was the way that a person was supposed to be put back together. And it's a little startling when you think of it, because we're the only discipline that manages a bone this way. If you think of facial-cranial or anything in orthopedics or any other surgery, any other discipline that crosses a bone and then has to put it back together, they use orthopedic principles to repair it, and we weren't doing that. So our randomized control study clearly demonstrated better outcomes for folks who had rigid plate fixation, and that was without a programmatic approach to managing the patient and structurally expediting the experience for the patient. And I guess my overarching goal in strategy has always been that we wanted to condense the patient's hospital experience. We wanted to make it so that they weren't wasting time sitting around, not getting better, not being mobilized, being uncomfortable. We wanted to get them back to their families and back to their lives. So we saw improvements globally in patient performance just from changing the way that we close sterna. And we made it programmatic. In other words, every surgeon switched. And then we realized that we could achieve more. And that dovetailed with, at that time, I was an author on the guidelines for enhanced recovery after cardiac surgery. And we took every bit of those guidelines and we worked them into our practice. And what we saw was that by taking advantage of the greater mobility, strength, comfort that patients were achieving, we were able then to really fully implement enhanced recovery at a level that's never been done before. Quite honestly, this has not been done before. This is the first time this has been reported this way. And what it led to was, as a system, as a program, everybody participated. So if you ask our respiratory therapists, physical therapists, nursing staff, administrators, including hospital administration, people in the operating room, housekeeping, if you ask any of them about this program, they will be able to tell you about it because they watched it change and they watched the experience for the patients. So that's how I think I went on a long story there, but that's how it got started, and that's where we went. And then when it came time to decide how to present this data, I realized that we were the only program that had really done all of it. So we published a single center study.
Yes, I think, first off, thanks for the answer. I think the long-winded answer really explained what the process was and, certainly the motivations behind doing the study. I think the way the data have been presented is intelligent and is also sort of to the reader, explains the natural evolution of your practice, at Franciscan Health. Because you have 4 cohorts, and, the traditional cohort is the cohort which, received the usual wire circlage procedure of, approximating the bone. And then you had, sort of the ones where rigid plate fixation was utilized. And then you had early adoption of both rigid plate fixation and the enhanced recovery protocol. And then once the entire group was, fairly entrenched into both rigid plate fixation and the enhanced recovery protocol, that was when that's the 4th cohort. And sort of my understanding is that these cohorts are fairly matched as far as their baseline characteristics, are concerned. And then you report outcomes, when it comes to, hospital stay and, particularly, length of stay in critical care. And I think what's striking here is the significant decrement, to almost not almost, actually zero, opioid prescription. When I say opioid prescription, I say morphine prescription. Do you want to specifically delve into these 4 cohorts for the listenership? As an author, any differences, in their characteristics and, how the process evolved when you were putting this together?
Right. So, indeed, when comparing the 4 cohorts, there were no significant differences in preoperative status, surgery they received, or in fact, we even looked at, surgeon to patient relationships. In other words, were those the same? And so fundamentally what it showed us was that our practice didn't change over time as far as the people we were treating, same level of acuity, same level of complexity, redos, et cetera. So the 4 cohorts were well matched. The control group received, as you mentioned, standard wire cerclage closure of their bone. And then at that time, we had not implemented the enhanced recovery program. So they basically were what people have seen for the last 40 years, the standard closure and standard recovery, standard limitations in mobility. And I don't think people can argue they remained, of course, exposed to the possibility of the complications related to that type of closure. So then the second cohort received rigid plate fixation of the bone. This is, on the heels of our randomized control study, and we standardized it across our program. And the following segment, the following group of patients, were also receiving then our implementation of the enhanced recovery protocols as outlined in the guidelines. So the guidelines came out, we started the process, and then the last cohort is after we had really refined the entirety of it, had everything up and running, felt that we had plateaued in our, and that plateaued in a good sense, in the sense that we were ubiquitous with respect to the application of the protocols, and we had achieved our goals. And so during that time, we fundamentally saw that patients just were more mobile, more comfortable, and then didn't really need the opioids. So people don't really want them anyway because they make them foggy, they make them constipated, they make them unstable. And so we had to pick something for this paper. When the original version of this paper is about twice as long and includes a lot about mobility and other aspects of it that we might touch on, but we thought we would just point out that as a consequence of what we had done, not that we weren't trying to take away opioids, we were trying to make people more comfortable, more mobile, and give them a more rapid recovery. And a consequence of that, so an outcome of that, was that they didn't need opioids anymore. And basically we kind of ratcheted back on their availability a little bit, and we noticed that the nurses weren't even giving it to them anymore. And then we ended up with just having some intravenous opioid available for the first 8 hours after surgery, and then the nurses weren't even using that anymore. So it was really kind of a consequence of what we were doing. It wasn't so much that we were trying to take the opioids away as much as we were trying to make the patient more comfortable, more mobile, and able to just kind of live well without requiring those pain medications. So in the paper, you'll see that at the same time as the opioids go away, overall pain scores actually drift down. So in the absence of opioids, the pain scores were actually going down. And at the same time, we saw a full day reduction in length of stay. And that's not us trying to get people out of the hospital faster. That's patients being ready to leave sooner. There's nothing else about our protocols that really changed. Shorter time in the intensive care unit, less time in the hospital. And I think probably if there was something that I really love the most about these outcomes is our 90-day outcomes, because we maintained a low readmission rate the entirety for every group, every cohort. It was fairly low. I think at our peak, we had a 10% readmission, and then we were at 6.5 by the end of the study. 30-day readmission. So below 10%, great. Everybody thinks that's great. SDS data says that's great. But we track everybody for 3 months. We still do that. And that final cohort only had a 2.9% additional readmission during the following 60 days after the first 30 days. So that is unique, because what it tells us is that people are getting back to their lives. They're not experiencing complications. They're not coming back to the hospital for other things. And I think that all of what we do to enhance their mobility, make them feel better, get them to rejoin their community in a normal fashion sooner, dramatically impacts not only that front end, where they feel better getting back to their homes and back to their families, not having to be in extended care facilities. But it impacts it over the longer duration. There are a couple of things that you'll notice kind of if you look through the literature with respect to, for example, 1-year outcomes of surgical versus transcatheter intervention. And there's a very interesting subtle difference in the patient's perspective, even out to a year, when they have a transcatheter valve versus a surgical valve. And that told me that there was still something lingering there that had nothing to do with what was going on inside their heart, that it had to do with their experience as a human being going through heart surgery, that people weren't feeling fully whole and well quickly enough, or maybe ever sometimes. So that's kind of what we were at after. I think that, that sounds kind of broad, but the reality of it is it's really what we were pursuing was to get people to feel whole back to their lives. And then eventually we took away sterile precautions completely. In other words, we don't tell people they can't lift things. We don't tell people they can't drive. We don't tell people, and most importantly, we don't tell people where they have to live when they leave the hospital. So we saw early on, we kind of had this average, which is, I think, nationally about right. About 35% of our patients would go to an extended care facility. And of course, this is across a broad spectrum of patients, different acuity, different age. And by the end of the study, though, only 6.5% of our patients were going to an extended care facility. So it's a dramatic reduction in discharge to extended care, and therefore an increase in discharge to home. So when you think about the social implications of that, and then you think about the financial implications of that, because it costs a lot of money to send people to extended care facilities, that's where I feel that we've really proven something, that we've really demonstrated something important. Because you'll see a lot of literature, a lot of folks trying to figure out how to get rid of opioids. Fine, you have your different pain management strategies. But our reduction in opioids was a consequence of a holistic approach to managing the patient perioperatively that restored them to full mobility quicker and put them back in their lives with their families quicker. And as a result, we ended up having shorter hospital stays, more patients back home with their families. And that's where I think we had a really important impact.
These numbers are, excellent. I mean, I don't think anybody can refute that. If I would request you to enumerate, other than the technique of rigid plate fixation to approximate the bone, there is also the enhanced recovery protocol. Would you be able to enumerate some of the measures that you took as a program to ensure faster recovery for patients, opioid-free?
Yeah, thanks for asking about that. And the folks who do get the paper will be able to look at, we have a table in there, and then we also have supplemental data supplemental information that allows people to kind of get a look under the hood for a lot of those things to really understand what we did. And I would also add that anybody who happens to listen to this, if they ever want to reach out to us, we are always happy to share every strategy, order set, et cetera, because we did build order sets around the enhanced recovery protocols. So fundamentally, in the enhanced recovery protocol, we, in addition to creating a more sternal chest, we also then worked with our first line was our staff preoperatively to ensure that we address things like anemia, diabetes, made sure that people were on their appropriate medications. We established a bit of a prehab program, so mobility. Everybody receives the same instruction. People receive the same instruction with respect to preparation from a respiratory mechanical standpoint. So everybody was exposed to that in the same fashion. And then once in the hospital, we have our anesthesiologists are very much on board with us and work very closely with us. So every patient coming into the operating room received what's called an erector spinae block, which is bupivacaine injected into the fascial planes in their erector spinae muscles. And that really takes off the edge of discomfort early after surgery. So that first 24 to 36 hours, where you just kind of aches and discomfort. And with that strategy, we saw that patients didn't require the early opioids, the fentanyl, for example, that people typically get, or morphine that they get typically right after surgery, just eventually evaporated because patients were comfortable. And this is all based, the nurses make those decisions. They're the frontline people. They have those medications ready to give if they need to give them. But they were managing the patients, and they would recognize whether the patient was comfortable or not, and then would appropriately or not give them those medications. We also, at the same time, liberalized the use of dexmedetomidine, which is a really nice medication to just kind of take the edge off of anxiety and general discomfort, or even when people are having trouble sleeping, to help them sleep. Because really the hospital is the worst place to recover. It's noisy, you're uncomfortable, there's all kinds of sensory input. And Dex does not suppress respiration, but does create kind of a general sense of comfort. So I have to say we did liberalize that. We also have a protocol of using lidocaine for its analgesic effect, which starts in the operating room and stays on board for several hours to a day after surgery. We use gabapentin instead of kind of standard pain medicines, other opioid type pain medicines, but we have really kind of even limited that. So folks that are over 75 years of age, we use either a reduced dose or none. And then for patients after surgery, if they exhibit any kind of neurologic issue, they're foggy, they show any globally neurologic issue, then we just stop that medication, because sometimes it'll have those consequences. The most important components, I think, with respect to how the patients experience the protocol, though, come into play with the staff at the bedside. So our nurses are immediately prepared to mobilize the patients. Our patients stand within 4 hours of getting to the intensive care unit. They are walking the next day. And the day after surgery, postoperative day 1, everybody's up in a recliner. Nobody goes back to bed the entire day. And that allows us to take advantage of the fact that they are comfortable, and the fact that they are not foggy because they're not on the opioids, and they mobilize and they walk 4 times a day. So respiratory therapy, physical therapy, staff nursing are all very much focused on taking advantage of these qualities and ensuring that the patients receive the entirety of the enhanced recovery program. Otherwise, we have some other kind of not unusual strategies with respect to pain management. We will use Toradol or ketocorlac for valve patients. We don't use it for coronary bypass patients. And of course, that's also restricted based on whether the patient has any renal dysfunction. And the rest of the enhanced recovery program is based off of the fundamentals of patient management from the time they're in the operating room to the time they leave. So while they're in the operating room, we have criteria with respect to oxygen delivery while they're on cardiopulmonary bypass. We have our set limits for anemia protocol for transfusions, which are low. We don't transfuse very often. We have very low transfusion rate. We have protocols for intravenous iron when people are anemic. We have protocols for strategically managing any evidence of acute kidney injury. And all of those things are built into our order sets of enhanced recovery that expedite the recovery.
Excellent. Thanks for going over, all the components of the enhanced recovery program. As someone who was trying to implement this, as you said, ubiquitously, system-wide across the spectrum of all your partners in your practice, how did you? For lack of a better word, how did you circumvent physician inertia, if any? If you encountered any physician or surgeon inertia early on as you were adopting this, what were some of the strategies that you employed to circumvent that?
Yeah, this is a question. I get this question a lot, actually. I think that we have certain advantages One of the advantages, I always say we run a boutique, not a department store, because we have this kind of very focused attitude about patient management, and we're able to do it because we have the appropriate scale for that. And that is hard to achieve. When, for example, anytime forever, since, I've been in this particular program for 17 years, whenever we make a change, we all make the change. And so we already had that as kind of our background, where order sets were all the same for all the surgeons, that we would be driven by evidence, and that if a physician or a nurse came up with something that they thought was better and that they thought we should implement, that we would look at it from an evidence-based standpoint, we would test it. And if it didn't look as if this was the next thing to do, the appropriate thing to do, then we would change it for everyone. So that, I think, we had this kind of baseline expectation that we were all had the same understanding that we were trying to do evidence-based medicine, take care of patients the same way. So then when I specifically became involved in rigid plate fixation and started to, beyond the study, use it for all of my patients, and my partners and I examined what we thought the outcomes were, and we partnered with the hospital in making decisions with respect to bringing in what was actually fairly substantial investment in every patient. And then, as you can see from this paper, we collected our own data. So every time we bring anything new into the program, into our ERS program, every component of it, and in fact, we have a test that we just brought in that we're evaluating now. We have some monitors that we're trying. Every time we bring in something that we think is going to take the game up, that's going to make it better for the patients, accelerate recovery, we arrange with administration to collect data that shows us both the outcomes, implications, and the financial implications. Because I think we have to be good stewards of how we manage what we spend taking care of patients. And we can invest upfront if we have something that brings us value at the other end, but you have to prove that. So I think that my partners and I have always kind of had respect for the notion that we could do something better for the patients. And then by using this methodology, where we always collect data and we always demonstrate what our outcomes are and set goals at the outset. In other words, when we bring something new in, we define what the expectations are. These are our goals. And if we meet those goals, then we will retain the technology. If we don't, we do not retain the technology. And folks in our program will tell you that that has happened several times, that we brought in device or equipment that promised a brighter future. And when we didn't find it, we didn't keep it. So I think that we just have the good fortune of having a team that recognizes the value of operating in an evidence-based medical practice and initiating things together and then testing them. But I fully recognize how hard it is to get people to change things. It's unbelievable to tell them. I'm startled sometimes when I'm talking to surgeons and the response that I get, that they can't have the expectation of having their partners do something. So that's how we did it. I would hope that is something that can be replicated, but hopefully just with more data, people are going to see what the implications are for the patients.
Yes. So, if someone who's listening to you, Dr. Gerdisch, asks you as to how long you think it will take for this to become fully operational for a new organization, what would be your response?
If we're talking about the entire program, everything that we do, in a nascent program that doesn't employ any or just very little of this, I would say if they had good buy-in, it'll take them 18 months. Because there's a lot of training. You have to go through, so many of the things that we do are shifts in the way that different practitioners manage the patients, that, putting up those kinds of order sets and then getting them up and running and achieving your goals. It's going to be more than a year. I can't imagine that it won't. It doesn't mean you won't get traction right away with a lot of it. You'll see benefit, but I think to get to this level, it will take quite a while.
Yes, and is there also a cost upfront which is involved, which, I mean, I know that you discuss that in the paper, which I think would sort of balance itself out because you are reporting a significant decline in readmission. How would a new program have that conversation with the administrators?
Yeah, so it's an odd thing to me because we actually showed it in the randomized control study early on that wasn't employed in enhanced recovery and was it was a multi-center study. So we had a randomized control study, multi-center and published that within 60 days, basically the entire investment was back because of a decrease in wound complications, just with that. But then if you layer on a shorter length of stay and then the dramatic reduction in patients going to extended care facilities, obviously, then that's where we see some substantial savings. Now, I think it's going to be different for different administrative environments. Franciscan has kind of a long game strategy with respect to patient management. They understood how important it was to me to look at 90 days, not just at 30 days, although that they get paid for 30 days. They understood how important it was for me to get people back home instead of an extended care facility. And that may or may not benefit the hospital itself with respect to the financial implications, but it certainly lessens the burden on healthcare finance. And then we did deliver, though, on the 30-day readmission rate. We did deliver on lower overall complications, and we did deliver on an entire one-day reduction in length of stay. So I just think that these are very logical conversations. I sometimes think that folks might be going to their administration just saying, we think this is a good idea. This looks good. We think it's a smart thing. Well, the administrator doesn't want to just hear that. The administrator wants to understand why it's a good idea and what the expectations are. I think now, based on the body of literature that we have, I think that a clinician can lay out a pretty convincing pathway, and then at least with guardrails on it to, start with some of the fundamental components of it, and then monitor their cost and see what the return on investment is. There should be a return on investment. You're right. There's an investment. That investment happens with every single patient. But standardization also is the key to success, right? So people say, well, I'm just going to use this for my high-risk patients. Well, I kind of feel like we should provide every patient the opportunity. We love them all. We want them all to do well. We want them all to feel whole. We want them all to recover quickly. So I think that if they can lay out the strategy and explain what the end game achieves, and by ubiquitous application, that's where you're going to actually see the upside. It's not doing it just in certain patients. You don't know who's really going to have a complication, but a ubiquitous employment of the devices and protocols that we know enhance recovery should achieve an overall improvement for the program. So I think that's the only way you can really sell it. Sometimes folks ask me to talk to a group of surgeons or something, and I will always say I'm happy to talk to them, but can you have their administrators join? Because it's important for them to hear it. If it's not a go with them, it's not a go with anybody. It's not going to happen.
Yeah. So when you put this through peer review, what was the toughest comment that you had to address from one of the reviewers?
Oh boy, that's a really good question. We had this was a really rigorously reviewed paper because as you mentioned, our median opioid use is 0. So first of all, we had to have our statistics evaluated a couple of times. They wanted to be absolutely sure that we had nailed it down perfectly. They really wanted as much information as possible in our management strategies, our protocols. So we do have supplemental information with the paper. And then also we have a table that outlines specifically the pain management protocol. They otherwise trying to think of like really a question that was challenging for us. I think that one of the softer aspects of the paper is something that is not avoidable. And that is, I'd have to look at the paper, but I think I framed it, I spoke to it as the aggregation of marginal gains, which I think we have to just recognize that, and actually recently in the TCT journal, the fellow that they talked to said, maybe we need a randomized control study to evaluate whether this is, really going to have this kind of impact more broadly. And I don't think we can do that. It would be impossible to do a randomized control study of this. Which patients are you going to do all of this for, and the rest you're not going to do it for? So the reason we were so successful, and that's what we tried to spell out, was that we looked at every logical next step and everything that we identified as clearly beneficial. And then we put those together. And as it turns out, as happens in systems analysis, especially when you have human beings at play, when you standardize and then you optimize, you achieve what you see here. But it can't be done in any lesser fashion. And that's why I kind of had to address it as that notion of we can't separate it out. One of the questions was, can you separate it out? Can you say which one is doing more? What's having greater impact? Is it the enhanced recovery protocol? Is it the rigid fixation? It depends on the human being you're talking about. There are some people that might be fine not having an orthopedic repair of their bone and still get through this process in a similar fashion. But we just don't know who they are. So that I think was the thing that I had to answer most with them. They wanted folks who were reviewing the paper wanted to be a little more analytical on what the individual contributions were of the process, and I can't do it. We have to recognize that it is a consequence of an entire program, and that program has to be maintained. It has to be tweaked all the time. We made a point of not changing anything until the end of this data set, but just after that, we added a specialized type of chest drain, believe it or not, that then we saw a significant reduction in perioperative complications and even further reduction in length of stay. And then on top of that, more recently, our median time to extubation is 0 hours. So just over the last couple of years, since we finished this study, we have made strides that are, again, aggregate as a function of the platform that this provides. I couldn't get to a median extubation time of 0 hours without all of this in the background.
Yeah, no, the fantastic answer. And yeah, I think it's at times we just get too analytical and want to prescribe a value to each step, which I think, like you mentioned, is a continuum of several steps in succession, and when put together will give you the desired outcome. And it's just hard to parse out, what are the specific, weighted ratios for each of these steps to derive at a particular outcome. So, congratulations to you on this stellar work. And, I really am looking forward to seeing more work in addition to what you've just published in Annals of Thoracic Surgery. Any closing remarks, Dr. Gerdisch? Anything you think we haven't covered during our conversation? I think if we've tried to, cover the paper as comprehensively as we could.
Yeah, no, I think we did cover it pretty well, and thank you so much for having me on. I think really my only closing remark is that we should all take advantage of this opportunity. I'm very passionate about how this has changed the way that people experience heart surgery. We have wonderful heart surgeons and great heart surgery already. I think that, our next task as a discipline is to alter the way the patient experiences it more globally. Thanks again for having us on, though.
Yeah, no, thank you. Excellent closing remark. And, for those of you who are listening, we will share the link to the paper in the show notes, in addition to the coverage that the paper received at tctmd.com. For questions, comments, and remarks, do write to us. We can share Dr. Gerdisch's email in the show notes as well, as well as our email at Radcliffe, and we'll make sure that we forward your comments to Dr. Gerdisch. Please review us and rate us on Apple Podcasts and SoundCloud and Spotify or any other podcast platform that you use to tune in. And until other Monday, thank you for listening.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.